I think we can probably go ahead and get started. Ian, if you want to kick us off.
Sounds good. Good morning, everyone. Welcome to part two of our combined June-July Mprrac meeting. Um, let's go ahead and make sure we have our members here. So I'm going to run through our Mprrac members. So Christopher, I see. Good morning, Christopher. Um, do we have Manisha?
I don't see Manisha yet.
Okay, let's come back to that. I see Nicole. Good morning, Nicole. Do we have Kate Leslie?
Yeah, I'm here. Nice to see you, Ian. I'm going to keep my camera off today because I had one of my facial surgeries this week and I have a large bandage, but I'm here.
Sounds good. Kate, wishing you well and great to have you here and have you back. I see Megan Adamson. Good morning, Megan. And then Tim. Do we have Tim?
I do not see Tim on the list.
Okay. So we are missing Tim and Manisha. Have we seen her join yet? I don't see her here.
Not yet. Let me send her an email.
Why don't you send her an email? We do have quorum, so why don't we go ahead and get started? And I believe we are going to go through the intro slides again. Then we will skip forward and start with dental. And so Michelle and Tim, I'll pass back to you to go through the introductory slides.
Perfect. Thank you so much, Ian. All right. So here's our agenda for today. Like Ian mentioned, we're going to go through meeting structure, logistics. We'll start with, sorry, that's the goal there is not correct. That was from our June 26th meeting. So we're going to start with dental today and go through to the end of surgeries. We may not need a lunch break today. We'll kind of play it by ear, but if we do, it'll be usually right around 11:30. And we know that these meetings tend to be very long. So if you can't stay for the whole thing, don't worry. You can always send your email feedback to our team email address there. I will put that in the chat as well once I'm done with my little spiel here. So feel free to email that, any feedback to us. It'll still get shared with the Mprrac if you're not able to speak today during the public meeting. And then we'll go through next steps and announcements and when our next meeting is and adjourn right around 2. Next slide. So we do have a new Mprrac member. Her name is Nicole Hardy-Swan. She's a great addition. I want to pass it to her for a little introduction.
Thank you, Michelle. My name is Dr. Swan. I'm Nicole Hardy-Swan. I'm a licensed clinical psychologist in Colorado. I'm a specialist in early childhood and neurodevelopment, and I own Swan Clinic for Behavioral Health, which is a ABA organization, and Exploration Kids Therapy, where we do speech and occupational and physical therapies, as well as mental health therapies and testing. And I'm
Thank you so
excited
much.
to be here. Yeah, thanks, Michelle.
We're excited to have you. And we also do have 2 HICPUF employees that are new, starting with Andy, if you'd like to introduce yourself.
Sure. Yep. I'm Andy Cochran. I joined HICPUF about a month ago as a rate review analyst, and I'm excited to be here also. Thanks.
And we also have Bria.
Yeah, hi, I'm Bria Willert, and I joined the same time as Andy. So I'm an access to care reports and operations analyst, and I'm also excited to be here, be with all of you.
Thank you so much, Andy and Bria. Next slide. Okay, so just as a general rule, here's our housekeeping slide that we go over every time. Make sure to follow along in the updated appendices. Again, I'll drop the link to our website where those are in a minute. If you're part of the committee, please make sure to add Mprrac member to your Zoom name so people can identify you. If you're a public stakeholder, please make sure you sign up to make a comment before your service and limit it to 2 minutes. Not just limited to 2 minutes, but also please try to refrain from repeating comments that have already been made. Totally fine to be like, just wanted to echo what so-and-so said. But for the sake of time and to make sure that everybody can have the chance to speak, we want to just kind of refrain from repeating the same thing over and over again and to make sure we keep our comments to 2 minutes. Please make sure you identify yourself before speaking. Remember not to share any PHI. We're speaking in broad terms here, not in individual personal terms. And if you have any specific questions, it's much better to put them in the Q&A feature and not the chat box. The chat is really just for posting links, that type of thing. Q&A is we're gonna be able to track your questions much easier and faster that way. So if you have questions, use the Q&A, reserve the chat for the recommendations that the Mprrac are making and links and stuff like that. And here's our disclaimer that we have every time. The materials will undergo the ADA review after this meeting. A lot of the time our presentation and materials are being edited up until the meeting, so it's hard to have them go through that review beforehand. So we get them reviewed as soon as possible after the meeting and then reposted on the website. So just a heads up there. All right, and I'll kick it over to Kevin Martin.
Hello. So I just wanted to give a little bit of an update on the Joint Budget Committee and the budget process and all of that. I did want to remind everyone that the rate review process that we are discussing today is just one method that we review and adjust rates through. It is a longer process. We review everything on a rolling 3-year cycle. The intent here is to make sure that things don't fall through the cracks and that everyone gets their time for review and that we actually get around to it on a regular basis. But there are necessarily times when we have to act quicker than once every 3 years. And sometimes we have to act quicker even than the review that is happening within that same year. So those usually get kicked off at some point during the budget balancing process around the end of the year when we're scrambling to balance everything and make sure that we don't over or underspend the budget. But there's just no way for it after we know exactly what the budget is going to be, and then we get all of the information coming down from leadership at the governor's office and the legislature, and then they come back to us with what they want to do. It just isn't feasible to also then bring that out to an additional public forum because those do go through the legislative public forum. But I just want to make that very clear that this is just one means that rates are reviewed and adjusted through. Also, here's a link for budget requests. You can see that we have budget requests every year from the department. These, again, are another method by which things change. I would also say that there are often budget requests that are informed by the prior Mprrac processes where we have not been able to take action on something and it feeds into either a broader review or investigation. We perform that and then it feeds into a budget request that sometimes adjusts rates. Also, here you can see the Joint Budget Committee hearings and their schedule. Again, all of this is public, so you can go out there and see the different forms that this comes through. And last time at the prior meeting here in June 26th, we had a discussion about last year's budget was particularly difficult, and we were not able to take up any of the recommendations through the Mprrac process, and hoping and my request was that we try to prioritize or have some additional context in the recommendations, or maybe dual recommendations, or just something. I was requesting some additional information in our recommendation process here so that we could maybe take up something. Because one of the problems last year was just that we had a big bucket of recommendations without prioritization. And so when it was just put forth as one whole package, it was just a lot of money that we did not have. And so we couldn't really act on any of it. And in the prior meeting, what we did was we had the committee was giving us ideal recommendations and pragmatic recommendations. And I'm hoping that that will work out better this year. We're still just sort of testing it out. And I really appreciate that. That is absolutely optional. There is no requirement for the committee to take into account budget actions. It's more just that anything we can do to get some additional context helps us so that we can follow the spirit of the desires of the public as much as we can. And just to make sure that I have summarized that or caught all of the things that are pertinent, I'd like to open it back up to the committee to see if they have anything they'd like to add to that.
Yeah, I think, Kevin, I think the discussion we had at the June meeting was good. I don't think we need to fully repeat it, but I think just to summarize from my perspective, I think we're trying to balance two things. One is the sanctity of Mprrac. We're supposed to look at access to care and benchmarks and make a recommendation objectively on the data, and we are not legislators or we don't make the budget. And so really just analyze the data as it comes to us. And then secondly, this process needs to be helpful. It is not helpful if we spend all of last year and literally every single recommendation is ignored. And so I thought that the ideal and pragmatic was helpful. Ultimately, it is not our call what gets implemented. And I think just having more granularity in our recommendations can only be helpful to the various stakeholders who are involved in this process. I would also add, we had discussed that in the next meeting, in the August meeting, we would have a Mprrac review of basically the full list of recommendations of ideal or pragmatic, and basically say, what's our top, we didn't say an exact number, but like a top 3 or top 4, like where did across the whole cycle, like where did we think that the biggest priority should be for the department and for the state. So I would recommend that we do that in the August meeting as well. But I thought that worked well. Any other comments from the Mprrac members on that, or are folks feeling pretty good about how we've been approaching it?
I think we've got a good approach going, given the constraints that continually arise.
I agree.
Great. Okay. I will take that as a thumbs up. If anyone has any other feedback, please feel free to speak up. Otherwise, I think, let's keep going.
Okay. Well, thank you very much for that. And we can go to the next slide, and I'll pass it off to Brian.
Yep. Good morning, everybody. Delighted to be here and facilitate our second summer meeting here and follow through. As we mentioned before in the first meeting, just quickly we'll run through some of these slides to reiterate for those who were not able to join in the first one. But we are a legislatively appointed body that functions with the department. Impact members are not staff of the department. And the staff, though, is tasked with synthesizing all the actuarial analyses into the reports you have here, as well as the appendices, which I want to call your attention to. Thanks, Michelle, for dropping the link to that in there. Lots of good detail in there for everybody. The recommendations that emerge from today may result in future budget actions by the department, but all changes must be approved and appropriated by the legislature. And the review of the services, and including analysis and recommendations, does not guarantee rate changes, as Kevin mentioned, whether either increases or decreases or changes to policy. And this committee does not submit budget requests. The budget requests are submitted by staff on behalf of the department itself. The budget process submission is independent of our review. And as I mentioned, we do not have authority to change rates without the legislature. Some quick rules of governance. This team has been really amazing on these. We continue to increase our ability to self-govern, and is to have our chairs and the committee really operating most of the key decisions and working through the process. So I'm really grateful for that, and keeping a respectful environment for all of us, one at a time in terms of speaking. Everybody staying mute unless you are directly engaging. We are always tough on the problems facing Colorado and easy on each other here. And let's continue that record, and using the past just to describe a better future and how we might operate. And then everyone has been, as usual, coming prepared, having reviewed all the materials and gathering the input from their community, stakeholders, and colleagues, and sharing that. Quick reminder on our terms here. We do have a number of terms ending at the end of this year, in January 2027. So you'll see those highlighted in orange. One actually goes to, and you go to 2028. And then, so if there are interest in another term, we've clocked that here, and that process will continue throughout the year. We'd love to have continuity where possible, but also if folks have had it, then there'll be opportunities to look for new folks as well. So our structure remains the same annually, right? We had our March meeting with the preliminary data, our 2 meetings here in June and July to discuss each of the service areas in detail and get recommendations from the committee. In August, the department comes back with sort of the financial impact of that. What's the fiscal cumulative impact of the changes that have been recommended? There may be some final adjustments at that point, or other additional areas that need attention. And then that becomes the final recommendations. And then in November, we take stock of our year. What did we learn? What are some things that we need to do differently in this case, 2027? And we also do some of our training and other things in November. So for today, our purpose is very simple. We want to continue the work that we started in our last meeting 2 weeks ago, to provide the background data and analyses of the remaining service areas, starting with dental, as has been mentioned, and through to the end of the surgery services. And at this point, the committee will have, at the end of the day, clear definitions and recommendations for all of the services, and in preparation for the August meeting, where we get those fiscal impacts. All right, this says meeting minutes for March 27. Those were actually approved in our first meeting here, but I would make the note just for everyone. We did post the official minutes here for the first meeting. There were a number of requests to have that posted, so we did, but note that will obviously be amended with the work that we're doing today. So that's a temporary post, and the official minutes then will need to be approved in our August meeting as a collective for both meetings. And as we mentioned, and last time we did get approval on this, so those services that are ready for approval next year, 2027, were approved in the last meeting. So all of these were approved. If you would like to review those, please feel free. But we can move ahead. All right, so our analysis overview. Oops, we went back. So services under review for this year, we covered the first section there up through ambulatory service center in our first meeting, and now we're picking up, as I mentioned, dental, behavioral health services, and surgeries today. Now, our service analyses, just as a reminder, there were a number of requests and there's been a lot of work done by department staff for the data that you're seeing today. And we'll just recap that real quickly here. So you can see there are maybe 10 categories where additional analysis or research has been conducted, totaling up to 23 different areas, and in particular, NEMT, and then maternity, a number of areas, abortion, PBT, fee-for-service behavioral health, surgery, and anesthesia, all had additional analyses, even since the March meeting. And as a reminder, we have excluded codes without benchmark rates from the rate comparison analysis. However, the committee still needs to make recommendations on these services so that the excluded codes can be aligned with other codes and from a rate change perspective. So as has been the case the last couple of years, we're asking for 2 sets of recommendations based on the code situation there. If the codes have benchmark ratios, that's one group of recommendations, and we'll address those first. And then the second recommendation we're looking for is codes that have valid fee-for-service rates, but there are, for example, no benchmarks or excluded codes. And so we've handled those in a different manner in the past. And Ian, you'll talk a little bit about that when we get into that. Thanks. Quick notes on changes to cover all Coloradans. This is a program that helps children and pregnant people get health coverage no matter what their immigration status is. So Cover All Coloradans change has shifted certain behavioral health services from the ACC and the regional county entity, regional accountable entity capitation to a fee for service. And that's going to be effective January 1st of next year. The capitation payments and certain care coordination responsibilities are removed from the raise. Funding is going to be redirected from capitated appropriations to fee for service. And the Mprrac is designed to analyze historical data, not forecast prospective program changes. So more meaningful evaluation from the Mprrac perspective will only be possible after the implementation of this change and the collection of additional data throughout a number of years. So we're looking at the 2029 review cycle as likely where we'll have sufficient data to provide some input and some review for the committee. All right. That brings us to dental. All right. So dental services, we have the state dental plan and we have dental for people with intellectual developmental disabilities. The state dental plan. As a recap for everybody here, the total adjusted expenditures in the last fiscal year were $444 million, serving over 514,000 members. That was a decrease of 9% in members utilizing those services. We now have 1,868 active providers, which is a slight increase of a little over 1%. As we look at the benchmark and the rate comparisons here for other states, and we look at that Colorado reprice, we would be at 97.33% of that benchmark. And if we look at that against the commercial rates and reprice that, we would be at 87% of that benchmark. So looking at the codes and the rate comparisons here, we have 464 total CDT codes. The majority of utilization falls within the 60 to 140% of the ratio range. There are some extreme outlier ratios represented a small share of total utilization. But as I mentioned, we're at 93% for the benchmark states, and that is included 352 of those codes. And then for commercial rates, we have a much wider range of 31 to 178% of the benchmark, but the overall ratio is lower than the benchmark states, about 10% lower at 87%. And there we have 251 of the codes in that benchmark ratio. And you can see the spread here in the second table below as we think about, which of those benchmarks are, for example, between 60 and 80. There's about 31% on the benchmark states and about 54% on the commercial rates and the utilization across the top. As you move higher up in that ratio range from 80 to 100 or 100 to 140, you can see the changes there in the mix of how we benchmark against each of these areas. Overall, the state dental plan, the top 10 codes by utilization, and we measure these in decreasing percent of the total utilization. So line 1 there has the highest single percentage of total utilization. That'd be your periodic oral evaluations. That's about 7% of total utilization. And then the benchmark for that particular code is 83% against the states and 79% against commercial. And as you move down, you can see sort of how these mix in around. Some of these are fairly high, maybe 132 on, say, child prophylaxis, and others are much lower against the benchmark, even in the 60s, as you might see intraoral there in number 5. We do our outlier bubble chart now. Remember here, if you look at the size of the bubble, that's the indication of the amount. And then the Health First Colorado repriced is along the lower axis, and the percent as a percent of the benchmark, in this case against other states, is along the left vertical axis. Now, looking at the same, these are the benchmark comparison outliers below 60 or above 140 for the state dental plan. And summarizing, for all dental services, the access to care, we think here the provider stability metric showed essentially 14% entry and 13% exit through that 23-24 year, with 76% of providers remaining continuously active. Medicaid provider participation remains stable, reaching 37% in 25. The PUPY expenditures increased from 23 to 25, remained higher than Medicare fee-for-service and exceeded both the commercial payers and the Medicare payers in fiscal 25. And the Medicaid PUPY utilization was stable and higher than that of other payers from 23 to 25. The panel size, highest in El Paso County, moderate along the I-25 corridor in the Denver Metro. The urban panel size is showing a decreasing trend, largely due to a decline in the number of utilizers, and the rural panel has remained stable. The penetration rate show a mix of increases and decreases across the counties, highest in Hinsdale and the largest decrease in Cheyenne. The vast majority, 98% of members, live within 30 minutes of a provider. Do we have public comments?
Yes, we do. We have Asha Chinney first.
I'm sorry, I didn't catch the name.
Asha Chinney.
Asha, please.
Yes.
2 minutes.
Yes. Good morning, Mprrac members. Thank you for your time today. My name is Asha Chinney, and I'm a dentist in Centennial, where I provide dental care to patients, including those Medicaid. I'm providing comment today on behalf of myself, as well as for the Colorado Dental Association. I want to thank this committee for your important work to ensure Coloradans have access to Medicaid services. This group is integral to ensuring Colorado's Medicaid program is strong and robust in recommending data-informed rate review that supports Coloradans. We appreciate the HECPAF team and this committee hearing our feedback about benchmarking for Medicaid dental rates. As dentists serving patients who have Medicaid, our fundamental goal is to provide them with comprehensive and quality dental care to support their oral health and their overall health. The feedback we have shared with the committee and with the HECPAF about benchmarking is what we believe will help support Coloradans' access to dental care through Medicaid. As we have shared at previous Mprrac meetings, we believe the state should have a reliable, standardized, and data-informed benchmark for dental rates. As such, we appreciate HECPAF including the data from the All Payers Claims Database, also called commercial rates, in the considerations for benchmarking dental rates. Colorado All Payers Claims Database includes dental claims data. Many states do not include dental claims data in their all payers data. So we are lucky to already have this information available to us. This data is the most comprehensive information available that is based on Colorado specific information and represents the best picture of the cost of providing dental services in Colorado. While we understand that comparison to the other states has often been a tool for benchmarking, unfortunately, there is no information about how those other states benchmark their own rates.
We're at 2
Therefore,
minutes, Sasha. Try to wrap up.
Okay, therefore, we have no data about whether or not those rates are sufficient, sustainable, or appropriate to support access to dental care in Colorado. We strongly encourage the Mprrac to utilize the All Payers Claims Database data when benchmarking dental rates. We are advocating now for the methodology for benchmarking dental rates.
So we have to wrap up here.
Okay, we are sorry about that. We are aware that the state budget presents significant challenges for Medicaid funding right now. And thank you again for your time.
Thank you.
Thank you so much. Next, we have Kevin Patterson.
Welcome, Kevin.
Thank you. Good morning. My name is Kevin Patterson. I'm an oral surgeon in Denver. I'm also part-time faculty at CU Anschutz School of Dental Medicine. And most importantly, through thick and thin, I've been a Medicaid provider since 1998. I'm speaking today on behalf of myself and the Colorado Dental Association, where I'm past president and currently serve as chair of the Government Relations Council. As we've shared in previous feedback to this committee, we believe that in order to ensure an adequate dental provider network, it's important to establish a benchmark for dental reimbursement rates that reflects the actual cost of care in Colorado. If the benchmark is flawed, then any downstream rate setting, regardless of the budget size, risks being misaligned, resulting in difficulty keeping existing providers and, more importantly, recruiting new providers. We appreciate HCPUF including the Colorado All Payers Data Claims Database in the benchmarking considerations, and we strongly believe this represents the most comprehensive and Colorado-specific data set available. It captures actual utilization and pricing patterns across the state and avoids many of the distortions that can occur when relying on external data. As we've stated previously, we are acutely aware of the current state budget for Medicaid. We're not asking to increase spending given the current budget landscape. Our goal is to support the patients we see and their access to critical dental care. The Mprrac can support this by ensuring that dental rate setting is grounded in accurate Colorado-specific data that reflects the real cost of providing care. Utilizing appropriate benchmarks is the foundation for a sustainable Medicaid dental program in Colorado. Thank you for your time this morning.
Thank you, Kevin.
Thank you. And next we have Jeff Lottle.
Welcome, Jeff.
Hi, I'm Jeff Lowe. Can you guys hear me okay?
Yeah, 2 minutes, please.
Thank you. Thank you, Mprrac members, for your time today, and thank you for your dedication to the Medicaid program in Colorado. I'm Jeff Lowe. I'm a practicing dentist in Arvada, where I have served Medicaid patients since we started our dental benefit in 2013. I'm also the current president of the Colorado Dental Association. Today I'm speaking on my behalf and also on behalf of the CDA. As you already heard from my fellow dentist, we really recommend you guys adopt dental rate using the benchmark of the Colorado All Claims Payer Database. And we're grateful for your feedback in including this in your data. Dental has not had a full review since 2018, which has been 8 years for us. We had a limited review in 2023. This inconsistency in our rates has made it challenging for us to be able to recruit new members. We got a good influx of over 180, I think, when we got our limited review in 2023, including a number of specialists. I think we had 8 or 10 new endodontists, and I believe there was only one endodontist or root canal specialist before then that was actually accessible for Medicaid members to go see. So we really encourage you to try to look at these specialty codes as well and to take those points into consideration as well for specialist workforce as well. People might be within 30 miles of a provider, but it doesn't mean they're within 30 miles of the provider that they actually need to go see. Dentists set their fees based on many cost-driven factors, including if they're trying to grow their practice and may be willing to accept a lower fee schedule to attract new patients. Staffing costs, costs for physical infrastructure, supplies and equipment, lab fees, the time and expertise of the dentist. Medicare looks at these similar components in setting their fees, including the clinicians working required time to provide these healthcare services. We also have practice expenses like staffing and infrastructure. And since Medicare can't be used to benchmark for dental, we believe that commercial all claims payer database is a much more comprehensive alternative. I would like to also share a few high-level priorities for us as well. Preventive care codes such as cleanings, prophylaxis, sealants, or endodontic care codes, which is root canal and those related procedures. Also, prosthodontic codes we feel are very low because they have a significant lab bill associated with those that have increased a lot over the last few years as well.
Jeff, we're at 2 minutes. If you can wrap up soon, please.
All right. Yep. So I would just like you to focus on those particular areas, hopefully, when you do your review, and happy to discuss anything else with further detail. And thank you for your time today, and happy to answer any questions. Thank you.
Thank you, Jeff.
Thank you, Jeff. That's all the public comments we have.
Thanks, Michelle. Members, looking for recommendations.
Just a question for HICPUF. Is there someone, Lingling or others, who can speak to the use of the all payer claims database? And do we think that, what do we think about that as a benchmark here, just building off of some of the public comments?
I think way you are the dental analyst and she has interaction with the civic for the dental all payer data. Where would you like to speak up?
Yeah, so during our provider engagement meeting, and the provider from the CDA highly recommended using the civic data for as one of the benchmarks. And so we work with the civic to get the information and had a discussion with them. And the civic data has it is Colorado based and had a lot of providers and also claim data. So I think it's a pretty good comparison. CDA is the Colorado Dental Association Civic Center for Improving Value in Healthcare, and so the data is valuable. And so the comparison benchmark is addition to what do we see from other benchmark states.
Okay, thank you. Any initial thoughts or comments from members?
I would say the main challenge that I have with the all payer claims database is, again, just has not been a source of data we've used consistently. And so, like, conceptually thinking about where should these rates sit as comparison to that commercial data, as compared to like other states where we felt like we should be at least matching something close to 100% when we can, or for the codes that are, comparable to Medicare being in that 80 to 100% range. And so I feel like overall, when you look at this dental data as compared to other states. There are some that are outliers on the low end that potentially like could come up. I think the ones that are outliers on the high end are there for a reason, like those preventive codes, the dental sealants, like fluoride varnish. So I feel pretty comfortable with where those are sitting right now. I just don't, I personally don't really have a clear sense for where we ought to benchmark against the commercial data. It looks like it's sitting in the 40 to 60% range, but I don't know whether that is where it ought to be or not.
I would agree. I would echo that. It's without the previous information and just the shift in the way that that's being analyzed, it's confusing. And I don't know if there's prioritization of certain codes that should be based on utilization looked at and examined individually. So those are things that I think I would want more information about too. It's a little uncharted.
I think we should, we mentioned this, I think, in the June meeting, but I think we should wrestle with the commercial data more broadly in the November meeting. That's beyond the scope of this conversation, but it does make it hard to contextualize and makes it hard to be, you know, consistent across services when we only look at it in a few services, two or three services, but not others. And so just having more definition around when we look at commercial, when we don't look at commercial, I think would be a helpful improvement discussion in November, because I feel the same way that you feel, Megan and Nicole. It's like it's different than how we've looked at other services, and therefore it's hard to make a decision around it while still being consistent as a committee. But we can pick that up in November way.
Yeah, I just want to add one more history of this. When dental was reviewed previously, we were using the ADA data to do the comparison, but ADA stopped providing data for everybody to use in 2022. That's why we did this during comparison methodology.
Thanks, Wayne.
But as a place to start, I would suggest using the states comparison and bringing the codes that are under 80% up to 80% and leaving the others the same. And if we need a pragmatic suggestion, it would be just to leave the rates the same.
I would agree with that. I would agree with that, and then discuss more broadly in November how we're looking at these.
Yeah, I would concur with that as well. I think that's a reasonable approach.
I think just to build off of what you're saying, normally for Medicaid benchmark services, we look at 100%, not 80%. And so I would lean towards doing what you're saying, Megan. However, making it 100%. I'd also be open to like an ideal versus pragmatic of like below 80% to 80% for a pragmatic and below 100% to 100% for ideals. So we're trying to kind of thread the needle there, but I do want to wrestle with that we typically say 100% for Medicaid benchmark services would be sustainable. Any reactions to that?
I just want to clarify, when you say of the benchmark, we're talking about the state benchmark or the commercial?
I was saying the state benchmark.
Yep, just wanted to hear it. Thanks.
mean, I certainly can feel comfortable with the recommendation to bring the codes under 100% to 100%. And then I don't, we didn't hear any like specific testimony about where or there being sort of a deficiency in where the codes currently sit, and just the point of prioritizing the preventive codes, which I think are already the ones that are sitting over 100%. And so, like, again, most pragmatically, I think it's sort of leave it the same is what I would suggest. Although I don't, yeah. It's all like phased recommendations.
So to synthesize, how about an ideal recommendation of bring codes under 100% of the benchmark up to 100% of the benchmark, and leave those above 100% alone, given those are tied to some of the preventative codes the stakeholders mentioned. The pragmatic would be to not make a change. And then that would be for our number one. And then for our number two on this slide, we would do this standard 3% inflation adjustment that we've done for other codes.
Yeah, I agree.
Yeah, that would be the way to do it.
Okay, great. If there are no other comments, Megan, can you try and type that into the chat again? And then to the question that came in the chat, I believe this is correct, but these are Ling benchmark to the new rates that are effective. Like this isn't benchmarked against an old rate. It's like post rate decreases the numbers that flow into this these slides.
Fee schedule used is October 2025 fee schedule.
Michelle?
Just a reminder to stakeholders, any questions that you may have, please make sure to put them in the Q&A and not the chat. They can get lost a little bit in the chat, so just don't want that to happen. Q&A is a better feature for specific questions.
Okay, great. All right, Megan, thank you for putting that in the chat. Any other comments from Mprrac members or dissenting opinions here? All right, let's keep going.
All right, dental DIDD. So again, this is the second grouping here of services under dental that we'll analyze separately. Here we're looking at about 6.9 million in spend for 2,700 members over the 24-25 fiscal. That was an increase in almost 8% of members, and we had 863 active providers, which was a small increase of 2%. Benchmarking those against the state dental plan, the DIDD comes in at 140, almost 7% of that benchmark. So we had 529 codes with benchmarks, 226 were excluded. Among the codes with benchmark ratios, we have a very wide range, 41 to 346%. Looks like 144, about 2/3 of those have benchmark ratios between 140 and 200, and that's almost half of the utilization. About 50 or a fifth of those codes have benchmark ratios above 200%, accounting for 20% of the utilization. So we're in a rare case where 0 are below 100%. I guess rounded 0% of total utilization. Sorting these by utilization as a percentage. Number one is your periodic oral exam. That comes in at 160%, and that's 12% of total. At 110%, your prophylaxis adult. That's another 8%. Topical fluoride varnish, 106%, and down the line. Our outlier bubble chart. This is the DIDD versus the state dental plan as the benchmark. And you can see again, most of these are, well, all of these are over 100% over the benchmark, and some are quite over, including one at 280% of the benchmark on the far upper left. Others sort of cluster there in the middle, around 100 and say 40 to 200. Panel size here, highest in Park County, moderate in Mesa and El Paso, and lower in others, although several counties had unavailable data. Urban panel size was stable, and rural showed some more month fluctuations month to month. Penetration was highest in Washington, with increases in some others, largest decrease in route. And the vast majority, 98%, live within 30 minutes of a provider. Public comments?
Yes, we have one person signed up, Jeff Lodell again.
Welcome back, Jeff. 2 minutes, please.
Hi, Jeff Lodell again for this CDA and myself. I think you guys had previously decided to do about 150% of whatever you decided for the Medicaid rates, and I think we were pretty good with that. Looking at your presentation and me, I think the sedation area is the one that a lot of these members probably need sedation, and they seem to be a little low for the mild sedation, and then I think for the general anesthesia they were higher. But I think the other point is these are often done still in like the oral surgeon's office or different offices that don't have a separate facility fee they're billing out as well. So there's a lot of other costs in the sedation for those providers to take into account. But I think we're in a pretty good place if we land around that 150% of the Medicaid benchmark. So that's all I wanted to say. Thank you for your work on this.
Thank you, Jeff.
Thank you. No other public comments.
Members.
Yeah, I think that was going to be my question. We did talk about the like aligning the review of these codes so that the DIDD services could be compared to the baseline dental services. So I'm curious, like where these codes compare to those codes. Are they at the 150%, or are some of them sitting in a different space? And I to continue to support the idea that it just makes the most sense to compare like services and just be paying at a higher rate for the patient population that kind of just needs more intensive support.
We had talked about this, I can't remember if it was last year or the year before, but there should be a premium paid for this because of the additional time that goes into the provider serving a member with IDD, as well as the access to care benefits, patient benefits, and health system benefits that come from proactive dental care in general and specifically to this population. So I think we had talked about roughly, I don't think there's a magic science between how much of a premium, but I think we had said sort of like 150%, 140%, something like that. And this looks very consistent to me with that. And so, yeah, it seems to me at a level that we should probably leave alone. And so that would be my recommendation for pragmatic, is just to leave it alone. If we wanted to make a targeted adjustment to one or two codes, like the sedation code that was called out by the public commenter, I'd be open to that as well. But I think we're like pretty much in the strike zone.
Yeah, I would second all of those comments, especially focusing a little bit more on the sedation part, because this is a population that is near and dear to my heart, and I can concur with everybody that lack of access and preventative issues can cause big problems down the road. So yeah, I would say we should focus on that as well.
I agree. I think the sedation is a specific piece that helps with that access.
So, how about we do an ideal of any sedation related code? I see at least multiple here, that is under 150% up to 150%. Otherwise, leave codes alone. A pragmatic recommendation of leave codes alone across the board. And then for the number 2 on this slide with no benchmark, we would do a 3% increase.
Yep, I would agree with that.
I concur.
Yeah, I support that. I guess I do have the question of, are the codes currently all sitting at 150% of their like comparator code? Because that is what is not included in this data. We're just seeing how it compares to the state rates. And again, in this case, it just wasn't how we were making the comparison previously.
Lingling?
Oh, could you please move the slide a little bit earlier, like in the beginning of DIDD? Yes, here. Next slide. Yep. They have 11 code. It's lower than the regular dental rates, but they don't have utilization data, means there's no fiscal impact.
Thanks, Ugly.
And of the 22 codes that are between that 100 and 140, which ones are those are the ones, Megan, you were like wanting to just like get more data on in terms of how it compares to what Colorado's currently paying out and where it compares within that 150% of that, correct?
I'm just trying to make sure I like understand this correctly. So this is saying that amongst the DIDD codes, some of them are 41% of the like their comparator code, and some are 346%,
Yes.
as opposed to like comparing how other states pay DIDD dental services.
No, it's compared to the dental plan rates, the regular dental rates,
Okay.
not bring other states. Because
And
as I
that's what we had talked about doing, right? Is like compare within the Colorado Medicaid program. Normally we compare to other states, but given the unique characteristics of this service, we would compare to Colorado Medicaid rates.
Right. Okay. So I think that sort of changes how I feel about this, right? Like then it makes me curious, why are some of these rates at almost 350% and why are some at 41%? Like again, I think we heard at least the sedation codes maybe should sit someplace higher than the 150, but is there reasoning why others are sitting so much higher?
don't have an answer. Janelle, are you here? She's the DIDD policy specialist.
I am here. And I'm sorry, can you repeat the question? Or actually, let me make sure I understand correctly. You're wondering why some of those rates were over 300% of the state plan rate and some were as low as 40%?
Yes. I think that's Megan's question.
Okay.
Right.
Megan, let me know if I don't have that right.
No, I think that's correct, right? Like if this is compared to the standard state plan, then we would hope that most of the codes would be in this column that says, 140 to 200%, right? They'd be sitting at that 150%. But then for the codes that are sitting, those 49 that are above 200%, what are those codes, and are they there with some intention or just out of coincidence?
Well, and my apologies if I don't know the history for how that inconsistency in the ratio of fees came to be. And I know that the initial intention was to ensure that those that were below the state fee were raised above, as we know that those reimbursement rates should be higher. And there was not going to be a way to increase that cost while also maintaining those codes that were 300% of benchmark. So I think the attempt was to ensure that all of those fees exceeded the state fees. And sorry, lost my train of thought. Without incurring a significant cost to the budget.
Thanks for that.
You bet.
Do we have any data on the codes that are in that 346% range?
It is in Appendix B.
Thanks.
So there are, if you look at that, you can see every single code covered by DIDD. Jeff, do you want to comment?
Yeah, I was just gonna say, so I think part of what happened is I think HCMA forgot to include the DIDD review in 2023 when we got our partial review for our codes. So that's why some of our like prophylaxis codes and perio codes are actually lower still than the Medicaid rates. So I think that's part of why some of those are really on the low end. I don't have much of any input for the 325% because I don't know what codes those even are. But I do know as a practicing dentist, that's why some of those codes are really low in the DIDD population. Is I think our review for DIDDs forgot to happen in 2023, and they didn't go up like they should have.
Thank you for that. Yeah, I mean, I think in that case, like my recommendation would be the codes that are sitting below 150% of the state plan should go up to 150%. And I would probably recommend that the codes that are like those 49 that are above 200% should go down. But just perhaps with the caveat of, the HCPF taking a look at what those are, and if, again, those are the sedation codes or something else where we feel like there is a reason for them to be sitting higher, then to potentially take some special consideration there.
Ling?
I want to clarify with Megan. You say for those code above 200%, you want to bring down to 200% or 150%.
I like where you're going, Megan. I would do an ideal of below 150% to 150%, above 200% down to 200%. Then for the non-benchmark codes, the 3%, the inflation, and then a pragmatic of not make a change. How would folks feel about that?
I think the pragmatic would be to bring those down. Because if we're trying to prioritize making sure that we're getting up to benchmark in other areas and being thoughtful of the budget constraints that we have by evaluating this against this, and I wasn't there for that meeting, but evaluating this against the standards that everyone said they wanted to set before, the pragmatic would be to bring those codes back to the 150. Bring them down, the codes that are exceeding those, that 150 threshold.
Yeah, I mean, I agree with that, that sort of from a pragmatic perspective, there probably is a need to bring the codes that are those extreme outliers down.
I guess then the ongoing question then though is if we're changing the way we evaluate rates, like is there an impact on that? Would there have been a difference between that and what we're suggesting now? Um,
I'm open to trying that and discussing further in the August meeting. My concern is that I count 49 codes that are greater than 200% of the benchmark, and we've gotten no deep public comment on those codes, and it's like quite a large change. And so I think like some amount of caution is reasonable for that reason. Um, but I'd be open to that. You're saying, Nicole, so the pragmatic instead of above 200 to 200, above 200 to 150, and then we can evaluate both the fiscal impact of pragmatic and ideal, and ideally have a better sense of which what these codes are that are above 200%, and review that at the August meeting.
with our ideal also bringing, I think especially we were talking about the sedation ones, those should be, I think if we're going to make those changes where we're bringing things down, the sedation implies access to care. And so I think that one has to be brought up to the 150 if we're going to bring those other ones down.
If just going through the rates in the appendix, a lot of the stuff that's well over 200 seems to be restoration, crowns and things like that. Sedation seems to clock in right around 200. So I think we're probably okay. I don't think we would hit any of the sedation with a reduction if we kind of go with that approach. The stuff that's 300 and 400, 300% is almost all restoration and crowns and metal bases and things like that.
Thanks for that context. I was trying to type up this recommendation, but I feel like I got a little lost on the maybe on the pragmatic end. So far I have ideal would be to bring the codes below 150% up to 100%, 150%, bringing the codes above 200% down to 200%. Okay. And then the pragmatic recommendation is, I think, where I got lost. Are we saying just bring all codes to 150% or something else?
I think it's the same as ideal, except on the above 200%, go down to 150%, not to 200%.
Sounds like we have a consensus.
Yes, let's have Megan type it up and just make sure we're all saying the same thing. And then
Yep.
For pragmatic, just the codes that are over 200% would come down to 150. Okay.
I was saying, and the below 150 would come up to 150.
Yeah, I got that part.
Yeah.
Thanks. Okay.
Yes. Yeah. Any other member comments here? Are folks comfortable with this? All right. I think we're good. We can keep going.
Thanks, everyone. Good work. Okay, we move into behavioral health services then. This is fee for service only. We have 4 areas: mental health, substance use disorder, integrated care, and behavioral health special connections service. All right. This is a new item, G2082, 2083, this ketamine codes, established patient, outpatient EM visit that includes supervision of esketamine, Spravato, self-administration, and required 2-hour post-administration observation period. We have G2, visit esketamine 56 m or less, and then visit esketamine greater than 56. Combined with the mental health services subcategory, and then compared to Medicare, reprice benchmark rates based on the place of service, adjust benchmark rate according to the percent utilization across facility and non-facility POS, and the findings suggest Colorado pays 73% of Medicare for both codes. Broadly, mental health services, total adjusted expenditures, looking at 27.4 million, serving almost 50,000 members. That's an increase of 5% year over year, with 3,100 or almost 3,200 active providers, and that's an increase of over 13%. As we look at that reprice, 27 million against Medicare or other states, that's going to be 78%. So on the actual rate comparison, we have 24 procedure codes here. 20 have benchmark ratios, 4 have been excluded. 18 use Medicare, and just 2 use other states. The benchmark ratio range is, let's say, 31% to 102, and 14 or 58% of the procedure codes have ratios between 80 and 100, and that's 93% of the total utilization. So there are a few, or about 6%, that's between 60 and 80 there, first row of the table. In terms of utilization, the vast majority, 60% almost, is number 1 here, and that comes in at 80%. Then you drop down from 60% to just 7% of utilization for lines 2, 3, 4, and on down the line. Bubble chart below 60% as a benchmark rate comparison. We do have this 30% complex interactive. That's quite low. Mental health services, access to care recap, provider stability. Entry was 53%, exit was less at 37%, and the continuity was right at 49% year over year. Access to care summary, the participation rate remains stable, slightly at 47% in fiscal 25. Panel size highest in El Paso, moderate along I-25 and the west. Urban panel size increased in 23, but decreased in 24, increased in 25. Rural panel has remained stable. Penetration rate showed mixed increase and decreases across counties, with the highest increase in Mineral and lowest in the largest decrease in Baca. Vast majority, and 98%, live within 30 minutes of a provider. The Medicaid PUPY expenditures increased 23 to 25, exceeding other payers, and the PUPY utilization increased slightly from 23 to 25, and was higher than other payers. Any public comments?
We have one person signed up, David Hatfield.
Hi guys, it's me again. I've got my 2 minutes, but I want to start off with thanking everybody. I'm a clinical psych and we just do a lot of stuff. Appreciate what you're doing, appreciate the data. I wanted to just kind of bring out though that the majority of the codes on your utilization are also medication evaluation and management with potential therapy service. Straight mental health services, so sessions where you sit down for 30 minutes up to 60 minutes with a patient and talk about things are all set between 79 and 82% of benchmark. And they only come up to not even 11% on your utilization. So those codes in and of themselves are a very small part of this. The rest of them all require medication management components, which no typical, social worker or family therapist or whatever can access. So we're in the middle of a mental health crisis. We all know that, and it's horrible. Our suicide rates are up, and we're basically paying 20% less than comparable states to keep our people healthy and surviving. I'm just, again, tight budget year, probably can't do it, but guys, I would love you to consider whether we can get this up, because the 44 or 45 or 49, whatever it was on maintenance surprises me. We don't have an adequate network around a lot of these areas. And I do teaching for the really hard crossover, folks with autism or intellectual disabilities and mental health conditions, which are 3 to 6 times higher. And this is the only model to even work with those folks and receive payment. So that's it, guys. You have a tough job. Much appreciated. Thank you very much.
Thank you, David.
Thank you, David. And no more public comments.
This is Kate. I just had a quick question for David. But first I wanted to clarify with HCPF. So these are fee for service only, right? So any of the therapy codes, what David was talking about, where you'd sit with a social worker or a therapist or a psychologist and do what we think of as therapy, those are all capitated services, right? They're all under our contracts now with the MCOs. So it's really rare that someone uses these codes to bill for therapy anymore. Is that right, HCPF?
It varies. Oops, I'm sorry.
Oh, sorry, go ahead.
No, I was going to say it varies by the array. Rocky is the most, in my opinion, and I don't have great data, but we do statewide services. Rocky is the most liberal in terms of supporting individuals with autism spectrum disorder and so they're inclined to do it. But anybody with intellectual disabilities is not typically getting served through Rocky nor any other array.
Okay.
And that's where it kind of comes into play. Thank you.
So thank you. That was a clarification. So depending on the MCO, and now there's just these 4 regions, only certain providers use these codes for really specific services like you described, David. Thank you. Yeah. And then does anyone know either the other services that are here that are the psychiatric codes? Is that similar for psychiatrists are using these codes outside of the capitated services as well? We didn't speak to that. Do you know, David?
Could we back up to that slide? Cool.
I'm honestly not sure on that one. I saw it.
I can't speak to it either because I don't know the psychiatric community as well. Yeah.
Just know it's very challenging. And so just kind of blending it out, guys, our folks are 3 to 6 times higher likelihood of mental health issues. Females are averaging, sadly, around 5 to 6 sexual assaults in lifetime. So trauma levels are pretty high. And again, I can keep going. Just know that it's a small group, but it's a group that's overrepresented in terms of mental health impact and also then likelihood of criminal.
Is there anyone from HCPF who does serve these codes on the call today?
We should have some of our behavioral health SMEs here. Nicole, are you on the call?
Hey, yeah, I am on the call. So I apologize who asked the question, but
It's Kate. I'm just one of the Mprrac members. Hi, nice to meet you, Nicole.
Hi,
Go ahead.
Kate. Nice to meet you. Yeah, the evaluation and management codes that are on this slide are only fee for service. And then all of the other codes that you're talking about, the therapy codes, are covered under our managed care entities, the MCOs and the MCOs, sorry.
The MCOs, yeah. No, but Nicole, my question was, do you know, are these codes the ones that are like outside of the MCO world? Does HCPUF have a plan for them? Like, do you continue to have them? Are you going to phase them out? Like right now, it's what David says is true. Each MCO can kind of decide for themselves if they want to even have these available. And I know historically, like some of the folks on the Denver side of the slope have started to like not use these codes anymore. Like you don't even have access to them as providers. Like they won't. Do you know if HCPUF is like going to phase these out completely, or are they going to keep these sort of separate pool of monies?
I believe we're going to keep them. I think the plan eventually is to move them under the MCOs, but I don't know that timeline.
Yeah. And do you know if other besides Rocky MCO, are there other members or I guess providers that are using these codes specifically for IDD and autism crossovers because they can't use the MCO codes?
I can't speak to that question.
Okay.
I apologize. I would have to ask an IDD IDD SME because I don't want to misspeak on that.
No worries. I just wanted to know if you knew it. Thank you, Nicole. I appreciate that. So just so the rest of the team understands, the reason I'm asking these questions is because most of us mental health providers I don't use these codes anymore. I don't even know how I would access them. I use all of mine directly through Blue Cross Blue Shield, which is, or CCHA, which is my MCO, and the capitated services we've done for mental health. And David, our stakeholder here, is telling us that these are essential codes, that they're still being used in certain communities. They're being used for certain types of people who don't have access to MCO codes. So, I typically, as one of the mental health members of and now we have a new member on Mprrac. Welcome, Dr. Swan. But I typically always advocate for these to be brought up to 100% if they're still being used, especially if they're being utilized by marginalized communities. So that's my recommendation, but I just wanted to get a little bit more context about them. So thanks, guys, for listening.
May I, Brian, real quick?
Yes.
Is it okay? Kate, we use those. I'm doing a lot of trainings around the state to enhance access for that group because of the higher prevalence of likelihood for mental health conditions and/or negative non-supportive environments that can lead towards those. So they're definitely needed. That's what I can put out there, and I'm trying to grow the base so that group can actually get mental health parity type access, because right now it's very, very challenging.
Members? Ling.
For Katie, thank you so much for your recommendation. I want to clarify. You say bring up to 100%. Do you mean all the code under this service category, or focus on the mental evaluation and management code as David brought up in the beginning?
Yeah, Ling, thanks for that clarification. No, I was just speaking about not the medication management codes, but let's see, let me look at these really quickly. Yeah, so it would be like the first two, the psychological treatment. Well, that's with E&M. I'm trying to think of the ones that typically are used by therapists don't have E&M in them.
So I suppose I would argue that if there are codes that include medication treatment that are also well below, and we're suggesting increasing to 100%, like, if people need access to medication treatment, then they need access, and it would make sense for those to align.
Yep. Agreed. And then David put the most used therapy codes in the chat. Yeah.
Thank you, David.
And I think on the whole, looking at this data, it looked like we got this pretty well in the range where it needs to be. And I think my pragmatic recommendation would just be to bring codes that are below 80% up to 80%. and in the like ideal setting can support the bringing those therapy codes and evaluation and management codes up to 100%.
I agree with that.
I do too.
I concur.
I think there's, and David, I think you can correct me if I'm wrong, and Katie, hi. There was a shift and some of this data might not be quite accurate because there was a shift where autism was recategorized from a medical diagnosis to a mental health diagnosis to change access for therapeutic intervention. So what was traditionally going through the state, then like and not getting paid out for services, we can now go through the MCOs. So I think some of this data may change over the next couple of years and has a direct like link to some of the PBT things that we were looking at, this being an alternative to it. And I think if like there will be some hope that we're able to do a transition where we can bring some of these codes up to decrease what we're paying out for PBT as well over time, because that represents such a vastly more significant amount of the budget than this does. So I just as a future like idea, those are one of the things that I want to kind of think about is how we can also kind of increase the access to that and reduce reliance on some PBT as well. Because it takes, I think, additional training and et cetera. So, but I'm fine with the pragmatic of bringing that 45-minute code up to the benchmark of 80%.
Megan's dropped it in the chat.
And I have a quick question regarding ground mileage. Is that the secure transport rate? Yes, that was the additional code added associated with the secure transport, the mileage-based code. Last Mprrac meeting, we were asked to separate that because it didn't really represent the situation surrounding utilization, since it was an add-on code to the ground mileage. Okay, thank you.
Thanks, Kevin. Members, we comfortable with Megan's proposal?
I'm comfortable with this. Are there any dissenters or any other comments from Mprrac members? All right, I think we are good. Can Kate, this question around the complexity code, someone will clarify what that means?
Is it okay if I?
Yeah, David, please go ahead. Yeah.
Thank you, Ian. It's an add-on code for the different sessions that recognizes complexity in service. It's something like $4 right now, additional for individuals that have different behavior and or emotionalism and or mostly communication patterns. That's where it's the most likely to be used. It's the one you guys had in that 33% or something of benchmark as your one slide pullout. That's all that code is. Now, having said that, guys.
Wait, hang on, David, before you go on.
Yeah.
Is it in the code set? Oh, that one.
It is in the code set. I see it as 90785 at 31% of the benchmark. So
Then,
yeah, that would be covered here.
Then that gets included in our recommendation.
Mm-hmm. Because that it's not only David for the issues related with like high behavior, but also like when you have complexities with suicidal ideation and homicidal ideation and coordinating care with calling additional services. So that it's just for an increased risk session and usually a lot more coordination of care.
And that would be included in the increase. Yep.
Yeah. To bring that up to 80%. Is that what you're saying?
Yeah.
Yeah, I agree with that. Because then I think it takes into account some of those more severe cases and just that one specific modifier, kind of adding that to supplement some of the ones that are high risk cases in sessions. And there's in audit, so I've been through an audit recently. And in audit, there's a high standard of documentation required for some of these complexity codes. And so because of that, because there is a high standard for documentation, I think that bringing that complexity code up makes sense for supplementing some of the things, that David was saying in terms of, you know, for the more extreme cases, we're really trying to get access to those care providers are more likely to be able to sustain those services with that complexity code raised. Do we have utilization on that complexity code, by the way? No. Okay. So I don't know what the budget impact would be then. And
we
I have
learn
to,
that. Oh, sorry.
Yeah.
We can learn that impact in the August meeting.
Okay.
They'll be able to calculate that. That may be in the appendix. I haven't looked. So
Yeah. So the pragmatic then would be to bring that 45-minute therapeutic code up to 80% and the complexity code up to 80%.
Yeah, really any code that is sitting below 80% right now. So it would be inclusive of that complexity code, but any other codes that were sitting below 80%.
Does that work, Nicole? Do you have any other concerns there or questions? Okay, I think we are good. So yes, that code is included, and I think Brian, we can keep going.
Yeah, thanks. Good work, everybody. All right. Again, fees, behavioral health services, fee for service only, SUD services. So total adjusted expenditures here, just 91,000 for 334 members. That's a decrease of 45%. I do see an asterisk here. Reduced Medicaid enrollment during the public health unwind, perhaps, is the root cause there. 41 providers, and that is a reduction of 38%. However, repricing that 91,000 against Medicare and other states, we would be at 103% of our benchmark. We have 7 procedure codes relevant here, 4 with benchmark ratios and utilization, 2 are rate comparison only without utilization, and 1 is excluded. All codes use other states. Check Appendix C2 here. Benchmark ratio, pretty broad range of 56 or maybe it's 57% to 211%. Half of those, or 2 of them, have benchmark ratios between 80 and 100, and that's just 11% of utilization. 1, or 25%, has a ratio between 100 and 140, and that one accounts for 88% of the utilization. And then among the codes with those, 1 is below 60 due to low utilization. We did not do an outlier chart to ensure PHI. Panel size was highest in Pueblo, with Montezuma, and moderate in El Paso and some Denver. Urban and rural size trended up in 23 before going down in 20 the following year. Penetration rate was mixed, increase and decreases with highest in Delta and largest decrease in Pueblo. Majority of members, 87%, live within 30 minutes of a provider. Public comments on substance use disorder.
We do not have any public comments.
Members?
Just again, this is Kate. I think and maybe HICPAF or Ling Ling's team can speak to this, but one of the reasons I would also say that there's lower utilization is not just the unwind, but also because I do know that the MCOs have been in negotiations with covering more of the sub services and covering them at a good and marketable rate. So again, these are these like off pools of money that are through direct billing to Medicaid directly instead of through the MCOs. So I don't, are there, again, besides applying our typical pragmatic to it, I don't think there's anything else we should do. Does HICPUF want to speak to that more of these services, people are not billing directly to Medicaid anymore and they're able to bill their MCO more? Because I know that was a big part of legislation the last couple of years.
I mean, just to build off of that, there's only $91,000 that was billed.
Exactly.
So it's a very,
Exactly.
very low number.
Exactly. And there's been an increase in sub services. And I know that there's been work going on at the state level to get the MCOs to cover them more robustly. So they don't need to use this side quest anymore.
Okay, it's Nicole again from HICPAF. Yeah, that is correct. That the MCOs are covering more of the substance use disorder. So that's why we only see this small number on this side.
Thanks, Nicole.
Yeah, and then Nicole, do you have plans for these billing codes? Like, are you going to sunset them or just leave them here? Or maybe you don't know. That's okay too.
I don't know that one, but I can always look into it for you guys.
No worries. It's always interesting to me these like side codes because as David, our last stakeholder told us, they still are used by certain providers for certain weird things like that the MCOs just won't cover for some reason. So David helped us know that these last services were used for people who are IDD and psychotherapy and autism, which for whatever reason the MCOs keep separately and will not cover. So there's always like a side hustle that does need these codes. I just didn't understand. I don't do said services myself. So I don't know how they're being utilized by providers or what population are they covering using these. So.
Langley?
I want to clarify one thing. Nico, please correct me if my understanding is wrong. My understanding is all this fee-for-service behavioral health code semi-covered by MCO under capitation. Why the fee-for-service behavioral health still exists is because some members under special situation, they can't enroll in the rate timely. Sometimes they have the retroactive enrollment or something happened.
That's right, Ling Ling. That's right. You're right. I forgot about that. Yep. There's also just certain members who can't get enrolled in the MCOs. That's right. Yep.
I know this is a little anecdotal to the conversation, but seeing the Delta County reference in the slides, as it pertains to substance use disorder treatments and the rise of patients connecting in Delta County, they have a really strong mobile integrated health program down there. And one of the primary objectives of that mobile integrated health program is to connect patients to resources. So I'm actually proud as a mobile integrated health provider myself to see that even though it doesn't seem substantial from the information, I'm happy to see that growth.
Thanks, Tim.
I'll say that I feel overall comfortable with where these codes are. I feel like my only recommendation would be to bring the codes that are below 100% up to 100% and leave the others the same. I don't really feel the need to have a different pragmatic recommendation. I think that would be my single recommendation.
I support that, Megan. Same.
I support that as well. And I think given the very low dollars here, there's no need to do a second recommendation.
I support.
And then let's also just add the codes without benchmark rates to bring up to the 3% inflation adjustment.
Thanks, Ian.
Any other, sounds like we have support here. Any other comments from any members? All right, let's keep going.
All right, next up, integrated care services. It's a rate only comparison summary. We had 15 total procedure codes. With the rate only comparison is due to no appropriate FY25 utilization of the codes as a result of new programming. The 15 codes had benchmark ratios among those. All used Medicare as the benchmark, and the range is 78.5 to 95%. Any public comments?
No public comments.
Members? All codes in this category have a corresponding benchmark ratio.
So I would say this is a Medicare benchmark service, and we look for 80 to 100%. And I think pretty much every code is there except for one. So I recommend bringing the one below 80% up to 80% and then leaving the rest of the codes the same.
I support that.
As do I.
I concur.
Okay, and I think we don't need a pragmatic for this one, similar to the last one, so we can just have that be the single recommendation. Any dissenting opinions here? All right, let's keep going.
Behavioral Health Special Connections Service. This is a rate only comparison summary. The recap, we have 6 total codes. Rate only comparison, again, no appropriate FY25 utilization as a result of new programming. 3 codes with the benchmark ratios. All of those are from other states. See Appendix C3. The range is 53.6 to 104.9. There are 3 codes currently excluded. H1003 due to no benchmark rate, H1000 plus HD, and H1002 plus HD due to no benchmark rate. No comparable benchmark rate identified with further research and continuing research for future analyses. Public comments?
No public comments.
Members?
I think it's the same as what we just did with the behavioral health codes, the integrated care services is just moved to benchmark, but it seems to be, yeah.
I agree with that. Like, given that these are benchmarked to other states, we'd suggest bringing it up to 100%, and leaving the other codes the same, since it seems like it's, barely over 100%. And then I guess 3% increase for the non-benchmarked codes.
Yeah, I would support that. Any other feedback here on these codes?
Okay.
Okay, so that Megan will type that, but bring under 100% up to 100%, above 100% leave alone, and 3% for the remaining codes. I don't hear any other comments, so let's keep going.
All right, that moves us into surgeries. Cardiovascular, digestive, eye, ligamentary, musculoskeletal, and respiratory, and other. All right, use of Medicare health professional shortage areas, HPSA bonus in rate benchmarking. This is new. So key consideration here, the Medicare HPSA bonus is a targeted location-specific 10% incentive. This is not part of the base PFS rates. Applies only to services in designated shortage areas, not all providers or services, including it as a blanketed adjustment would distort the benchmarking. Potential impact on the 25 claims, assuming all surgical services are qualified for this. And you can see we have all surgery codes in row 1 there, line level claim count, number of procedure codes, 3,800, number of utilizers, 153,000. So total paid amount here would be almost 80 million. Surgery services provided in the HPSA, that would total about 300,000. And the HPSA percentage here of the total amount would be something like 4.42%. And the conclusion is use unadjusted Medicare PFS rates for benchmarking and consider targeted policy adjustments separately if needed. So going to surgeries, cardiovascular, we have about 8.5 million for 9,200 members. That's a decrease of 5%. Total active providers, almost 2,600, or down 4%. Repricing that 8.5 million would be about 86.3%. The rate comparison here, we have 755 total codes. 742 have benchmark ratios, 13 excluded. Among those with the codes, 97% use Medicare. The range is highly variable from 8% to 355%. But 75% of the codes have ratios between 80 and 100, and that's 44% of the total utilization. You have insertion of an artery catheter is number 1, 13% of total utilization, for example. That's at 87%. If you look down, there's a few that are below 80 here, but not far below 80. We have a couple up in the 140 range on the far right, and then the small cluster of those in the 60s on the lower left. Welcome, Manisha.
Thank you. I'll fill you in more later. Thank you.
Of course. Again, cardiovascular system, summaries on the access to care, provider stability here, 21 in, 20 out, about 68% remaining active. Provider participation increased from 40 to 45% year over year, or from 23 to 25 over 2 years. Panel size was highest in El Paso and Arapahoe, moderate in the I-25 in Denver, stable across both the urban and rural. Penetration showed a mix of increase and decreases, highest in Phillips, largest in decrease in Pitkin. The vast majority of members lived within 30 minutes, that's at 95%. Medicaid PUPY expenditures were lower than other payers, and the utilization was higher than other payers in 25. Public comments.
No public comments.
What do you think, members?
I have some questions. Were these codes impacted by the across the board decrease to like 85% of Medicare or whatever happened to that like broader code set? So we heard about that impact when we discussed the anesthesia codes and the ambulatory surgery center codes a couple weeks ago. So I'm a little surprised to see such a broad range as comparison to the benchmark for these codes.
These codes are included in the 85% reduction. The 85% reduction is for if the benchmark ratio is already above 85 or bring down to 85. For codes not compared to Medicare, it will not. It will not be. It will not receive the reduction, and also it was compared to 2025 Medicare rates.
Is that different than what we were looking at for anesthesia and ambulatory surgery? I'm just trying to understand how, if all these codes got reduced to 85% of the Medicare benchmark, how we're seeing some of them kind of well above and some below.
Give me a second. Let me bring up my data here. Okay, Kip, you want to go ahead?
Yeah, the reduction to the 85% of Medicare for the surgery codes, that reduction only considered the non-facility Medicare rates.
Yes.
And was not based on utilization. In our review, and this is the way it's typically done for Mprrac, is we look at the place of service where wherever the surgery occurred, whether it occurred in a facility or not in a facility. And if it occurred in a facility, we apply for that particular claim, we apply the facility rate, which is generally lower. And then another thing that also impacts this is when that 85% of Medicare reduction was implemented, that used the calendar year 2025 Medicare rates. Right now, for this current review, we're using the 2026. So the change from 25 to 26 isn't as big of an impact, but it does have an impact. The biggest one is the facility and non-facility Medicare rates.
Right. Okay. That makes sense. I think we saw a little bit of drift in those other code sets, but they all kind of hung around that.
Yeah. So this will have the biggest impact on surgery because it does make a pretty large difference for some codes. The Medicare rates for facility and non-facility for a handful of codes are vastly different. So, not all, but some of them.
Right. Just one more thing is, when we do the rates, because these are for utilized codes, it is not a rate only. So it's not rate compared to rate, it's the repricing cost. And also we have multi-surgery discount rules applied.
Thanks, Wei. Other questions on cardiovascular?
I think my perspective is these are Medicare benchmark codes, virtually all of them. We look for 80 to 100%. And so I think a rebalancing here makes sense to bring codes below 80% up to 80%, codes above 100% down to 100%, and codes within 80 to 100% to just stay where they are. How would members feel about a recommendation like that?
I would second that as a recommendation.
I agree as well.
Yeah, I definitely support that, and then I'm just thinking through my head of how to make a pragmatic suggestion, because we did recommend for that other those other code sets of just aligning at the 85% where everything had been adjusted, and have the kind of in my mind that is a potential really significant impact. But I think for consistency, that's what I might put out there.
Are you saying, Megan, like what I said would be ideal, and then a pragmatic would say take anything above 85% and bring it down to 85%?
Or would just be sort of aligning codes at 85%. It sounds like the non-facility codes were largely just transitioned to 85%. Is that, or am I misunderstanding what that change was that happened?
So there aren't non-facility codes specifically. So for
I'm trying to compare this group to the ambulatory surgery codes, say, that we looked at 2 weeks ago.
The ambulatory surgery center, because of the way it's priced in Colorado and because of how Medicare prices ambulatory surgery centers, for that cut to 85%, that wasn't included in that April cut that the department did.
Or if we look at the anesthesia services, I guess then would have been the one that we looked at last time. Was that all the codes were aligned to 85%, or codes that were above 85% were brought down to 85%?
So for anesthesia, they were all right around 84. That was because we had brought them, the department had decreased rates to the 85%.
So that's what I'm trying to clarify. Like the change that happened in April was that just all codes were brought that were above 85% were brought down to 85%.
Yes.
And those that below that stayed where they were.
Yes. Everything below stayed. It was just impacted things that were above. And it was the calendar year 2025 Medicare rates, and for surgery was the non-facility surgery rate. So every code that has a different facility and non-facility rate on Medicare, non-facility is always the higher of the two rates. So yeah, it only impacted the codes that were above that 85.
Thanks for that.
Mm-hmm.
I want to add one point for Megan for the April reduction to the 85% Medicare. For most code, that's yes, but they have some exemption, like primary care, some abortion code, neuro testing evaluation code, select maternity code, and the family planning code, and some NICO code. So they have some exemption, but very small percentage. Yeah.
Yeah, I feel like I understand why those codes were exempted, but I'm not entirely clear why the whole set of surgical codes in the facility setting would have been exempted from that.
A little bit complex. For the primary care, because of the value of primary care. So in the first place, the governor's executive order exempt the whole primary care code. And then we found for some code like abortion or neuro testing code, Medicare is not appropriate comparator. And for family planning, because the federal match is 95% instead of the regular 50%. So we want to maximize, keep the federal match, so exempt the family planning. And the family planning, you still can understand it. It's very important. So
I understand for those codes. I'm trying to understand. It sounds like this set of surgical codes was not impacted.
That's what it, yeah.
Why is it that this set of codes that we're looking at right now didn't see that same decrease in April, so that we're still seeing this really broad spread of
in Medicaid, there is no separate facility and non-facility rates. There is only one rate.
I think the root cause is still the different method. During the April reduction, we applying the Medicare non-facility rate only as the benchmark. But for the current rate review, the regular rate review, we apply both the facility and non-facility. So it naturally bring up some codes benchmark ratio very high. So you feel it's so brown and like dispersed everywhere. They still have some code about 100%. That's the reason.
So in Medicare for surgery code, you have non-facility rate and facility rate. But in Medicaid, we only have one rate. In the benchmark comparison, what we did is we did a weighted repricing for a given code based on facility and non-facility to compare with the weighted average of the Medicare rate.
And so that makes these codes look higher than 85% because of the benchmarking that you did.
Yes, because we did not just benchmark to non-facility. So if a surgery happened in a facility setting, for example, it's 20% in the facility setting and 80% in non-facility setting, then the benchmark rate from Medicare will be the weighted average of those two rates instead of just the non-facility rate.
For some cases, non-facility rate is more than $1,000. For facility rate, it's only $100. So you see the difference, the huge difference.
So I guess I'm putting this in the chat. I think this ideal is what I was saying. I think the pragmatic is what I'm struggling with of does it make sense? Is it logical to bring codes above 85% down to 85%? Which I think what Megan is trying to say is that would be consistent with how all the services were handled in April. And is that a logical thing to do or not based off of this different benchmarking methodology?
Yeah, I mean,
that's what you're saying, Megan, right?
Yeah, I think you've accurately reflected it, and I struggle with the same thing. Again, feeling compelled to make a pragmatic recommendation, that's what I would put out there. I definitely think that could have some significant impact and if not positive.
If I could, Wei, maybe, is there a way for the committee to see sort of the impact of this recommendation and as a practical matter, not using a weighted average approach, but separating out the root, sort of the source data for that average that may help them reach a better conclusion? Or is that data just not available because of how we priced this out and so on?
So you're saying instead of doing the weighted average comparison, we just compare to non-facility because the 85% reduction, or other things are compared to non-facility, right?
As an example, it might help them at least see the impact of this weighted average because it seems to be clouding their judgment a little.
I can prepare the data when you guys are discussing others, but because I can't have the data ready right now.
Oh, I know. I was asking for the next meeting maybe, but
yeah, I think if we have it at the next meeting, then that works. Part of the purpose of making two different recommendations is to see the financial impact of each of them and be able to make a final recommendation. And so, yeah, I agree that for this one, it may be helpful to have that broken out a little bit to understand, if Medicaid has a single rate, what is the impact if it's done in a facility versus if it's done outside of a facility?
Exactly. And I may go so far, in the November meeting, is there a reason why this one is treated so differently in terms of the weighted average that going forward, maybe we just, look at apples to apples instead of a weighted average next year as an example or in the future? Because this one's a little unusual.
I agree. It's complicated. The April methodology is because of the timeline. We don't have enough time to do the exactly same analysis as the current rate review. We just pick the non-facilities, very straightforward. And theoretically, if we use the non-facility rate as the benchmark, there should no code have any rate above 85%. Because we already reduced all of them.
That's an important point.
So I edited the recommendation to say that we would review this unweighted data at the August meeting prior to finalizing. So it's sort of like a temporary or not temporary. We want to look at that data before we feel good about this pragmatic recommendation.
I mean, I'm comfortable with that staying there, and it really is the purpose of having these two recommendations. Our final, we'll be making our final.
It's what we do anyways, yes, but I think in particular here, there's just,
As a
it'll help us all remember that there's an added emphasis here for the August meeting. Does that work?
Absolutely.
All right, any other comments or feedback here from Mprrac members on this recommendation? Are folks comfortable with this? Any concerns? All right, hearing none, I think let's go with what I put in the chat for surgery cardiovascular, and let's keep going, Brian.
Yes, thank you. I'll note there's a new Q&A if someone can take a look at that. Okay, digestive. So total adjusted expenditures, about 16 million for 39,000 members. That's down 9.5% year over year. We have 2,700 providers, and that's down about 3.7% year over year. Repricing that 16.1 against Medicare and other states, we'd be at 96.1. We have 883 codes, 849 have ratios, 34 excluded. For those that have, for among the codes with the benchmark ratio, 99% use Medicare, and we have a 9% to 361% spread on the benchmarks. About 70% have a benchmark ratio between 80 and 100, and that's about 65% of the utilization. You can see that in row 2 in the table. There are some, about 5% of utilization and 15% of codes that come in between 60 and 80%. And then there's some 28% between 1 and 140%. Looking at utilization, the biopsy would be number 1, about 19% of total utilization, and then on down from there. Pretty big spread here, but not, I don't see that 9% one here. These are like 79 on the low end and 135 on the high. There's the one above 140, actually about 160 in the far upper right. That's a colonoscopy, maybe? I can't see that font size. Yeah. Access to care. Participation has been relatively stable, right at 50%. Panel size highest in El Paso and Pueblo, moderate along I-25 in Denver and Western. Urban panel size increased before decreasing in 25, and rural has remained stable. Penetration rates, a mix of increases and decreases, highest in San Miguel and largest decrease in Bent. Vast majority, or 96%, live within 30 minutes of a provider. The Medicaid PUPY expenditures increased from 23 to 25 and lower than commercial, but slightly higher than Medicare Advantage and Medicare fee-for-service. Medicaid PUPY utilization was higher than that of other payers in 25. Public comments?
No public comments.
Members?
So on the whole, my recommendation for this category would be the same as the prior. I will say that I would exclude colonoscopies, those which look like they're right now sitting right around 130%, which I think is a reasonable range to sit. Obviously, those are a preventive like screening for colon cancer, and I think we want to prioritize folks having access to colon cancer screening. So yeah, that's kind of where I land at leaving those colonoscopy codes sort of where they are.
And you're just saying it's an important preventative service, and so we should. Yeah, that works for me. Any other feedback or comments from members there?
Can we look real quick at that one outlier?
The 79 or the colonoscopy?
Yeah, I mean, so I think this code, it probably makes sense to be closer to the 130% where others are. I don't have a specific, I'd have to look it up exactly, but why that one sits so much higher. But I think being in the 130% range would be appropriate.
Agreement with that on the 45381.
I agree. It follows the logic.
Submucous.
I'm trying to type it out.
Thanks, Ian.
What is, I can't see the number. Can you say it one more time for me? Sorry, it's just really
45381. I will note we haven't really emphasized this, and maybe now is a good time because we're actually picking out one outlier. You'll note there's an asterisk at the bottom of each of these slides. There are times when outliers just are not shared here in the data with you because of PHI. So, we might just keep that in mind as we tend to see some outliers. We show those when there's sufficient volume to be able to mask personal health information. But just keep that in mind.
Yeah, I appreciate that, and I think like conceptually we can just say we think colonoscopy should sit around 130%, and so if those other outliers are for other specialty procedures, then it would apply.
That may be a way to handle it, Megan. Thank you. Yeah, because that's the point.
Hey, Dr. Adamson, could you speak up just a little bit?
Oh,
for
sure.
us hearing impaired folks.
Sure thing. Yeah,
It would be hearing impaired old folks.
I was just saying that in my view, the colonoscopy code should sit around 130% of benchmark. And so just to the point that we're seeing one outlier, if there are other outliers that are not colonoscopies and are other procedures, then they would fall into the recommendations above.
If I'm looking at the Appendix B, like ratios, there's a colonoscopy with balloon dilation that's like one of those outliers that, Brian mentioned that might be in the 29, one of the 29 outliers, and that one's sitting at 268%. So I guess I'm trying to make sure I follow the logic, like prioritizing, making sure that like colonoscopies are all brought around, all colonoscopy codes are brought around to that 130%. Is that what you're saying, Megan?
Yeah, I think that's a fair place to start. Again, that balloon dilation sounds like it's probably more of a specialty procedure or like a management of something specific, because there are plenty of other reasons to do colonoscopies. But I think as a place to start, that would be my recommendation without going through code by code.
Yeah, because then once you get into it, then there are plenty of codes that are with colonoscopies that are around like the 92%. So, yeah.
So I guess I would specify like the intent is sort of to focus on screening colonoscopies or those that are done as a preventive service.
Yeah.
Yeah, it's a great point, Megan. If you remember a couple years ago, we used that as one of the guiding lights for areas that we thought deserved a little more protection in the rate world. If they were seen as strictly preventative, we tried to prioritize a little bit. We've lost that thread a little bit this year, but that's something that's been important to the committee over the years.
I agree with that. I like that logic. Then I guess the final recommendation we're making is move all those codes towards that 85% benchmark, except for the preventative diagnostic, like the colonoscopy codes, and those would go to 130.
Yeah, that's what I tried to do, and I just edited the chat. So breaking out between non-colonoscopy and colonoscopy, non-colonoscopy would follow our prior recommendation exactly, and then colonoscopy would basically, we just want to, you're saying basically just re-benchmark to 130%.
Yeah, essentially for sort of for preventive colonoscopies.
Just simplified it a little bit, just to say anything under 130, bring up to 130, anything above 130, bring down to 130. Does this work for folks? Thumbs up? Okay, great.
Thanks, Ian.
Let's keep going.
Eye and auditory. Here we're looking at about 2.9 million in spend for 12,000 members. That's a decrease of 10%. We have over 3,000 active providers. That's down 4%. Repricing that 2.9 against Medicare and other states puts us at 91.5 of the benchmark. We have 360 codes. 340 or so have benchmark. Among those, 99% use Medicare. Again, we have a wide range here, 12% to 172% against those benchmarks. 230 or 2/3 have benchmark ratios between the 80 and 100, and that's 83% of the total utilization. But among the codes with utilization, only one has above 140 and 12 below 60 due to low utilization. An outlier bubble chart was not created to ensure PHI. So broadly in the range here, but there are some 15% or so by utilization or 14% by codes that are between 60 and 80. And it looks like we have some either below 60 or above 140, but very small number. By utilization, remove impacted earwax. Number one, 26%. And then injection of an eye drug at 15%, and another 13% for impacted earwax. These range from, I guess, low. Row 3 is at 75%. Everything else is sort of in our range. Participation decreased from 49 to 47% year over year, but remained stable in 25 at 47%. Panel size highest in El Paso and Pueblo, moderate along the corridor, I-25 and Metro. Stable trends in urban and rural from 23 to 25. Penetration rates show a mix. Highest in Gunnison, largest decrease in Pitkin. 98% within 30 minutes of a provider. PUPY expenditures were lower than other payers, but increasing slightly from 23 to 25. And PUPY utilization remained stable over that period, higher than commercial, but lower than others. Public comments?
No public comments.
Members?
Any comments here from anyone or any codes that we should treat differently than the other surgery specialties?
I have a question. It's not specific to the codes, but I've seen this a couple of times where it says, where we're talking about penetration rates, and I'm, live down valley from Pitkin County. So I'm wondering why we're seeing do we know anything about the provider, enrollment rates versus penetration rates, like access rates? Is the change because there's a decrease in providers, or is it because, that's just untenable to live up valley? And if you're a Medicaid recipient for most of these incidences, because I'm just wondering, I just want to make sure. I work with a lot of kids whose families are up in that space, and so I'm just trying to figure out why we're having changes in this way in penetration.
Yeah, hi, Nicole. I can help answer that question. So, because Pitkin is a relatively small county with a low Medicaid population overall, it can make them more sensitive to changes. So, things that can happen with decreases in penetration rate can typically occur when utilizers decline more rapidly than membership, and vice versa. Increases in penetration rate are driven by declines in membership with relatively stable or modestly changing utilizer counts. So I think with Pitkin County, since it is a smaller one, it could just be a result of a shifting utilizer or count among the member population. But that is something that we can pay attention to and look into more in the future with these small counties like Pitkin County, especially with a service like this.
Yeah, I also work in Gunnison County, so this is right in my catchment area right here. So yeah, that would be great. Because I know we're sort of unique in our valley that a lot of families are driving, an hour to 2 hours to get to Pitkin County to work, and they don't necessarily live there, but then, so I'm just trying to get a sense of how that's shaking out on our side of the state.
Yeah, and
Thank you.
just to know, this is Kate. Like historically in our committee, we've asked questions of HICPUF like this where we want to make sure there's if we're increasing rates, that the idea is to increase also providers, like that there will be more providers showing up in rural areas because the reimbursement rates will be more market rate. And so that is one of our questions that we've asked the HICPUF before. But sometimes I found, this being year 4, there are just times where we can't always figure that out, like what is driving penetration or what's driving loss of providers into a certain area. And HICPUF's been really helpful in the last couple of years, I think, trying to help us see that because they're concerned about it too. But it doesn't always show up in our rate review meetings in the summer. Sometimes we talk about it in other meetings. I want to make sure I'm representing that correctly. Other members, feel free to jump in.
I think that's accurate. Like, it's helpful to have as context, but not always the easiest thing to make actionable.
And I think with seeing those, how there's specific areas that have, a percentage that they get. I think it was like the digestive, I think we were looking at, that had the higher, you get a bonus on it.
Yeah, they're based on their HPSA score.
Yeah. Just wanting to make sure that that's taken into account. And it's just interesting because it's Aspen, but that's where a lot of the families that like work in that area, they still access those services. And so I just want to make sure there's some equity in access too. Good, thanks. I'm glad it wasn't such a off the wall question. So thank you. Other than that, I'm good with applying same principles that we were discussing before.
Yeah, I agree with sort of the same as what we recommended for the cardiology surgeries.
Ian, are you typing that up?
I am, yeah.
Perfect. While you're doing that, I'll make a timing announcement. It is 11:30, and in a normal meeting, perhaps we would on a break, but there's just 4 more categories of surgery left for today. So I'll suggest that we continue for the next 4, and then we can break for the full day, and everybody can continue on their own. And but open to your feedback, members. If you would prefer a break, we can do that.
Are there more public comments, Michelle, just to get a sense of what's coming?
We do not have any more public comments.
Okay, then I think, yeah, I agree with that, Brian. We should keep going. Are members comfortable with that?
Yep, that's good.
Michelle?
One clarification in the chat, Ian. You had said match the surgery digestive
Sorry,
recommendation.
I typed
Cardio.
it wrong. Yes.
Right, okay.
Cardiovascular, sorry.
No worries. Thank you for clarifying.
You put it down the wrong pipe. Sorry.
Well said. Any other comments here from members on eye and auditory? All right, let's keep going.
All right, integumentary, total spend here about 11 million for 44.5 thousand members. That's a decrease of 7%. We have 6,500 providers now, down 1.6%. We reprice that 10 million against Medicare and other states. We come in at right about 85%. We do have 400 codes, 392 with some benchmarks. Of those with benchmarks, 99% use Medicare. We have a very broad spread of 3% to 493. But 58% have ratios between 80 and 100, and that's about 51% of overall utilization. But there are 31% of total utilization, or 17% of codes, between 60 and 80. And 3% below 60 or above 140. By utilization, here we have number 1, about 10%, kind of a lesion. Then we move down to 7%, 6 and 6, and down the line. There are a couple of these that are below 80. There's number 4 at 65%. And then number 5 at 71%. Number 2 at 75% as well. Bubble chart below 60%. We do have a few here. Access to care, medical provider participation has been stable, about increasing to 61% this year. Panel size highest in Pueblo and El Paso, moderate through I-25 in the Denver and some western counties, stable in both rural and urban. Penetration rates, a mix of increases, highest in Jackson and the largest decrease in Phillips. 98% are within 30 minutes of a provider. Medicaid PUPY expenditures increased slightly from 23 to 25, remained lower than most other payers, but slightly surpassed Medicare fee-for-service. And then PUPY utilization remained stable over the same period, exceeding commercial payers and exceeding Medicare fee-for-service in 25, but below Medicare Advantage. No public comments, I think.
Correct.
Members?
I would suggest same as previous, with the ideal and pragmatic.
I agree with that. Any other codes or codes we should treat differently or other considerations here from anyone? All right.
I guess, are there in, like, we were talking about colonoscopies earlier, are there any like preventative care codes that really do stand out within this specialty that we should know about?
No, prevention is sunscreen.
In
this category.
That's what I was thinking. I was like, other than behavioral.
Okay, I'm hearing match the.
I think we're good unless there's any dissenters. Okay, yeah, let's keep going.
Musculoskeletal. Here we're at almost 21 million in spend for 41,000 members. That's a decrease of 7%. We have 5,600 active providers, and that's down 2%. If we reprice that 21 million or so against Medicare, we come at 85.2. There's over 1,600 codes. Most of those have benchmark ratios, and those that do, 99% use Medicare. Again, we have a very broad spread, 12% to 315% here. But 72% of those are between 80 and 100, and that's 72% of total utilization. That said, there's still a fair number between 60 and 80. Actually, is there something off on the numbers? I'm not sure that the table matches. Oh, it's a percent of the codes. That's why. Okay.
Yeah, I apologize. I'm just seeing the typo for
Yep,
47% of utilization. I can fix that.
Yep, thanks, Cole. Yeah, so let's go with the table, not the summary above, right?
Yeah, that's correct.
Thank you. Yeah, so 47% are between 80 and 100. But there are some between 60 and 80 then, that 52%. Looking at specific codes by utilization, you have some drain joint bursa at 14%, injection trigger points 12%, and down the line. There's some in the high 70s here, quite a few in the high 70s, one at 66 on a forearm splint. Getting ahead of the question, are any of those preventative? I don't think so, but I'm not a doctor. Upper right, we have a couple outliers below 60%. Access to care, Provider participation has remained stable at 58%. Panel size is highest in El Paso and Pueblo, moderate in I-25, Denver, and Western. Panel size were stable in both the urban and rural over the last 2 years. Penetration rates varied. Statewide, highest increase in Rio Blanco and the largest decrease in San Miguel. 98% within 30 minutes. Medicaid PUPY rose slightly from 23 to 25, but lower than other payers, especially commercial. And PUPY utilization was stable from 23 to 25, similar to other payers, but although exceeded all other payers slightly in 25. Public comments? None?
None.
Members?
Same as cardiovascular.
Yeah, there's nothing like preventative here or anything.
No, these are all like orthopedic procedures. So most of the common ones we saw were like joint injections or joint needing to be drained, and then the less common ones are going to be in all the more detailed sort of orthopedic surgeries.
Okay. Sounds good. I just put that in the chat. Are members comfortable with that to match the earlier cardiovascular?
Yep.
Yes.
Sounds good.
Okay, great. All right, let's keep going.
So everyone. Respiratory, we have 3.5 million in spend for 13,000 members. That's about flat. 2,500 providers, also flat. Repricing that 3.5 million, we'd be at 89.5% of the benchmark. Over 300 codes here, 99% use Medicare. Range again, highly variable, 6 to 269%. But 62% are between 80 and 100, and that's 53% of utilization. There's some 26% of total utilization between 60 and 80%, and a very tiny percentage under 60 or over 140. Top few codes here: nasal endoscopy, diagnostic laryngoscopy, inserting emergency airway. You can see a few of these at 79, maybe just 2, right under the 80 percentile of the benchmark. One 140 outlier there, navigational bronchoscopy. Medicaid provider participation increased from 54 to 58% year over year. Panel size stable across urban and rural, highest in El Paso, moderate through I-25 Denver Metro, and lowest across eastern, western, and central Colorado. Penetration rates varied statewide. Ouray had the highest rate increase, and Baca reported the most substantial rate decrease. 96% within 30 minutes. PUPY expenditures are stable, but significantly lower than commercial payers, and similar to Medicare Advantage and Medicare fee-for-service. PUPY utilization remains stable from 23 to 25 and slightly higher than other payers. No public comments still?
Correct.
Members?
Same as previous.
I second that.
And there's nothing else here that needs additional emphasis. I don't think there is, just double checking. Members comfortable with this in the chat? All right, let's keep going.
Thanks, Ian. All right, other surgeries, 14.6 million for 43,000 members, down about 6%, 6,300 providers, and that's pretty stable. We reprice that, we'd be at 88% of our benchmarks here. Over 1,300 codes, 99% use Medicare. And we have the largest spread I've ever seen, 1 to 1,504%. 67% ratios between 80 and 100. And that accounts for 68% of total utilization. There are 18.9 between 60 and 80, and a small percentage below 60 or above 140. Broad mix here of other surgeries. This is one of everything. Couple outliers, over 140 here and then down at 60. Provider participation increased slightly to 58% last year. Panel size highest in El Paso, moderate in Denver, Western, and lowest across Eastern, Western, and Central. Urban and rural regions remain stable. Penetration rates were mixed across the counties, San Juan having the highest increasing rate and Hinsdale having the largest decrease. 98% within 30 minutes. PUPY expenditures slightly increased, 23 to 25, and remain much lower than commercial and lower than other payers by a noticeable margin. Medicaid PUPY utilization remains stable, 23-25, and higher than commercial payers, lower than Medicare Advantage and Medicare fee-for-service prior to their near equalization in 2025. Public comments?
No.
Members?
The only thought I had, and I imagine we'll have the same recommendation for this one we've had for the last several surgeries. I just wanted to note that it sounds like all of these are reimbursed significantly. That word kept showing up in the slides than private funded plans. And to me, I'm just asking a question, and this is not one that HCPF, I don't expect you to have the answer of today, but it does seem that that's a very strange ecosystem. So my guess is if, that people if you're a Medicaid member and you need these surgeries, you're going to have to go to a hospital to get them. Like, I know that there might be things about that I don't know in terms of like outpatient versus inpatient, but I'm just saying that doesn't seem like any of like a private practitioner or like an outpatient clinical hospital that would be able to like self-fund is going to be able to take Medicaid. It just seems like private practitioners and this are just they're not going to take Medicaid members. And the only place Medicaid members could reach these services and have them funded would be in like large hospital systems who can offset that cost. Is that a fair assessment? And if you can't answer it, that's fine. I'm just thinking long term, because this happens every year when we get to surgeries, just so everybody knows there's never public comment. We make our same recommendations. And I'm just thinking from my own anecdotal knowledge of this, most of those like more well-heeled private practice places they just don't accept Medicaid. So they're definitely not coming in to be public commenters to request Medicaid. So I'm just trying to figure out where members go to get these services. It would have to be in larger hospital systems who can subsidize the cost, right? And if no one can answer that question, that's totally fine. Just wanted to make it public. I just wanted to make that as a public comment. This is Kate, by the way.
Yeah, Kate, I actually appreciate you bringing that up, and others, please come forward after I make just a small point. We've noticed that as well. We've talked about that in our team about surgeries. We'd like to add to the November agenda, particularly after today, which just reinforced past practice, that we just didn't have a lot of comment from the public, if at all. And we'd like to see providers participating in this in a different way. So we would add
Exactly.
we'd add that to the November
Perfect.
session to try to ideate a really robust effort for next year, or the next cycle at least, to improve this. So.
And
Thanks, Brian.
I do want to emphasize, I believe, Michelle, if you could maybe share more of the details. I know you had mentioned you had done a good amount of stakeholder outreach. It's not for a lack of trying. I agree that it is. We don't have comments, and that is frustrating. But I do believe, Michelle, that we have put in the effort.
Yeah, that's correct. Cole Hoffman, he gathered this big list of surgical associations, and we reached out to as many of them that had email addresses. A lot of them only had those like web contact, like forms on their websites. We reached out that way as well, but either way, email or web contact form, we didn't get any responses. We did follow up again with those outreaches and still didn't get any responses. So yeah, it's definitely an item for the November meeting to discuss kind of what to do there.
Yeah, and it just from a policy stance, which again is outside our scope, but that means that Medicaid members are really relying on rural hospital systems, right, to get these surgeries, and that I know that rural hospitals are struggling. So if we lose a rural hospital, then there isn't another ecosystem I know that members could use this benefit in, especially if those private practitioners you guys are trying to reach aren't even interested in coming to advocate on behalf of their Medicaid members. Like just anecdotally, I have a friend who runs a clinic here for the spinal injections, and it's outpatient, and they have one Medicaid member a month who's allowed to become a new patient. So I don't think they're particularly interested in advocating for more.
Manisha.
Thank you so much. And my apologies again. I had a family emergency. I could not join in earlier. And along Kate's line, I really feel that this is so important to be represented in the diversity. And like Michelle and Brian said, that this is important on the agenda for the department as well. My whole point was I always felt dental was not represented well, and it's such a big divide in the healthcare community also, like, oh, this is the dentist, this is the doctor. Apologies again for not being able to join with dental with time, and I would love to answer if the committee has any questions about dental specifically, or there was something that was not addressed, and if there's anything that I can assist with now or in future. Thank you.
Before we get to Manisha's question, let's just close out this and get a recommendation.
Well, can I just add something? We did have like one comment that was sent to Michelle from a provider in the surgery section, and that was with I think it was the eye and auditory, that kind of spoke a little bit to what you were asking, Kate, about the difficulties with private practice making these financial realities work. So we have like at least one piece of anecdotal evidence here, kind of telling us what's happening. It falls along the lines of what we're saying the concerns generally are in this area, that moving straight over to hospitals, and they don't have a great long-term outcome for what it looks like we're going to be providing access in the rural challenges that they face.
Thanks, Nicole. Wait.
Okay, I just have a question to clarify on the additional analysis requested for the surgery. We mentioned we want to review the unweighted facility and non-facility data in August meeting, right? So I want to clarify exactly what is needed for this analysis, because our team has different understandings of this section. So do you want all utilization data to compare with non-facility rate in Medicare, only instead of weighted, or do you want to use like all utilization data compared to non-facility versus facility, right? Like, or you want to use utilization data happened in facility setting to compare to facility and non-facility setting to compare to non-facility.
Is this to answer my question, Wei? This is Kate.
Yeah, it's the additional analysis you want to see.
I actually don't know if you can do this analysis because what I'm trying to capture are the private practitioners who don't even take Medicaid, right? Or they take one patient a month. And I don't know if you can capture those people. And I am assuming that they're outpatient, right? That they're not affiliated with the hospital system. I appreciate your request for clarification. I would actually defer to you as the data experts. How can you show whether or not most Medicaid members get these type of surgical services in a hospital or not? That's the question. I don't know the best way to answer it.
I think y'all are I think we're talking about two separate things.
Okay, thank you.
Thanks, Ian. I was gonna say the same thing.
So I think, Wei, to your question, let me share more what I think we're trying to get out of the analysis, and then happy to talk about what analysis makes sense to support that. But I think we have the ideal and the pragmatic. For the pragmatic, we have seen the state move codes above 85% down to 85%. And so Megan had a suggestion to do that here as a pragmatic recommendation, which could make sense. That is hedged a little bit by the fact that I don't feel like I fully understand facility-based reimbursement versus non-facility-based reimbursement. And does that 85% analysis or that 85% potential bring down actually make sense or not? And so how does the use of facility reimbursement versus non-facility reimbursement impact the committee's decision to recommend going down to 85% of benchmark or not? And I'm happy to connect offline around that, but if you all want to think about it, but I think that is what we are trying to answer is, does that 85% of benchmark recommendation make sense, particularly for the facility codes that I think were previously like carved out of the work that was done in the spring?
I think because Megan's suggestion is to map the methodology differences between the April 1st reduction versus the current analysis. So my understanding is you want to see, for the pragmatic recommendation, you want to see, is there any code about 85% using the non-facility rate as the benchmark source to replicate the April 1st analysis? That's my understanding.
I'm not sure about that. I was thinking more of option 3 of facility versus facility, non-facility, the options that were presented. But Ian and Megan, this is your thought.
Yeah, I think we're trying to get at the difference between the facility and non-facility rates. And if that change in April only impacted those non-facility rates, like really understanding what would be the impact of any of our recommendations, because the relationship to benchmark was based on a blended, sort of something blended between those two rates. Yes. And for me, it's kind of understanding, where do the non-facility rates fall in comparison to a benchmark, versus where do those facility rates fall as comparison to a benchmark, right? And are we somehow under or overpaying on one side by having a single rate? But it all gets to the same point of trying to understand what is the impact on a provider who may be operating outside of the facility setting. Are they somehow being shortchanged by having this rate set the same? Or how much are we impacting our members by having that sort of difference?
Okay, you want to compare to facility and non-facility separately. Okay, thank you.
Kim? Yeah, that's what I understood.
Yeah,
I just wanted to say we only have the one rate. So it's the benchmark.
It's the
So
benchmark. Yeah.
it's the benchmark that has the two different options, and the benchmark is weighted depending on where it happened, but it does, because if there's a ton of utilization in a facility and a little bit of utilization in a non-facility, like in an office, then we're pulling more of that. The weighted average is leaning heavily towards the facility rate, and when there are the two different Medicare rates, facility is always lower. So it does have an impact, looking at just non-facility rates versus this blended average that we use for a benchmark right now.
Right. So thank you for that
Yeah.
clarification. So it's almost sort of like using just the facility rates as a benchmark and then separately using just the non-facility rates as a benchmark and being able to understand.
Do you like to see the three side by
I
side,
think
like our
it's 3
current
columns.
blended, the non-facility and facility, and then you can see the three overall benchmark ratios side by side? Because what would change is not our rate. What would change is just the benchmark itself.
Yeah, absolutely. The 3-column comparison would be great.
Yeah, look under the hood of that weighted average, right? What's in there? Okay.
Okay, I just want to make sure. I don't think we actually approved
Yep.
this recommendation for
We
this
got to go back and back. Yep. Thanks,
slide.
Ian.
I just want to make sure that folks are comfortable with the match the surgery cardiovascular recommendation for surgeries other. I think that's a thumbs up. Okay, so I think we can keep going. And then let's go back to Manisha's question. We did cover dental. I think we felt pretty good about dental, but any other questions or comments from the group around dental before we keep going? Okay, great. And we will have time in August to review the recommendation again.
Yes.
At the next meeting. So I think, Brian, we can keep going.
Yeah. Yep. Thanks everybody for circling around a couple times. All right. So overall benchmark ratios. This is our recap. Going back to the last meeting, it just gives you a sense of where we stood on each of the service categories and the subservice, if any. And more from today. All right. So next steps. So this is not true. We've done part 2, but our upcoming meeting, the bottom half of this is true. We will meet again August 21st from 9 to 2. So hopefully your calendar is clear and focused on us at that point. We will at that point have the combined notes and minutes for approval. So take a look at those. Those will be distributed to chairs briefly and then available for review. If there are any edits or questions, we'll take those at that time for both meetings. I want to be clear. There you go. And posted a week after the meeting, this meeting. So we'll see the draft notes, if you like, ready in a week. And I think that's it for my part.
Yeah, thank you so much, Brian. Again, if there's any final feedback, extra feedback, any questions, comments, concerns, please feel free to email our team address, which is that top one there. If you'd like to contact me or our manager, Ling Ling, our emails are there as well. And yeah, I can put those in the chat one final time as well. Next slide. Okay, Ian, I'll hand it over to you.
All right, I think that wraps. Thank you, everyone. We can adjourn the meeting for today, unless there's any other final comments from the group.
I just want to say, thank you for the in-depth analysis, and I really appreciate the conversation that we've had over the last couple meetings. I feel like it was very helpful.
Yeah. Agreed.
Agreed.
Thanks, everyone.
Thank
All
you.
right, we'll adjourn. Thanks, everyone.
Thank you so much. Have a great day.
Have a good day.